Slidell Memorial Hospital, your hospital for life.
Hello and welcome to another edition of Health Quest, St. Tammany's response to meeting the medical information needs of you, the citizens of our parish. My name is Bruce Clement. I'm the executive producer and host of the show, and it's great to be back on the air in 2018. We're going to kick off this season, with a very prominent physician who practices in Slidell, Louisiana, and actually all across St. Tammany Parish, Dr. Janine Parker. Dr. Parker is one of those unique physicians who is qualified in many areas. She is board certified in 4 different specialties, which in and of itself is amazing, Dr. Parker. So I want to know, Dr. Parker, thank you very much for your generous offer of time and to help educate the people about chronic obstructive pulmonary disease. In this segment, we're going to talk about the disease itself, but I want to know a little bit more about Dr. Parker. So Dr. Parker, what interested you as you were growing up in medicine?
Ever since I was a child, I knew I wanted to be a physician. My mom was a microbiologist. I've got an aunt that's a nurse, an uncle who is a pathologist, and it just seemed what I was destined to do. Yeah,
so it was sort of a natural evolution, and you had all of this family support network that was very much involved in medicine. Well, I think the community is very lucky to have this very talented individual working for us. And you can see Dr. Parker in a sleep lab as a board certified sleep physician. You can see her in an intensive care unit as an intensivist pulmonary specialist, as a pulmonologist. Which one did I miss?
Internal medicine.
In internal medicine. Who would have thought, right? So we're happy that you're here today. All right, so COPD, a very common term. We see it a lot on television now. Is it a disease or is it a collection of diseases? What is it?
COPD stands for chronic obstructive pulmonary disease, and it actually encompasses emphysema and chronic bronchitis.
All right. Emphysema. Let's spend a few minutes talking about that. Emphysema is a disease, classified as a disease?
It is.
Okay.
It is destruction of the terminal lung units, the alveoli. Instead of having a cluster of grapes, you get one big sac. And obviously, since oxygen is picked up from the capillaries surrounding the little clusters of grapes, when you just have one big sac, you lose surface area, and therefore you can't absorb oxygen and get rid of carbon dioxide as easily.
We're going to talk more about the causes and treatment about that, but in your practice, what do you see as like the #1 cause of emphysema? Is it environmental? Is it genetic?
It's cigarettes.
It's cigarettes. It's
cigarettes,
smoking.
cigarettes, and more cigarettes.
Wow. Okay. And yeah, we'll talk more about that.
Yes.
Now, chronic bronchitis. What do you have to do to be, what criteria do you meet to be, for bronchitis? First off, what is bronchitis? And then why, what makes it chronic?
Chronic bronchitis is coughing up mucus daily for 3 months at a time, every 2 years. So people who typically every morning they get up, they cough, they clear mucus, and it can come in episodes, but it is an ongoing process. It's not like acute bronchitis where you get a viral bronchitis and you cough for a week and you get over it and you move on. These are people who cough and produce mucus all the time.
Wow. So in our next slide, if you would turn to the number of people who are affected. So we're looking at this map of the country, and we see that 24 million, and I'm sure this date, this is 2013 data, probably higher.
It has.
It's increased over time.
And you realize that this is only capturing, we estimate 6% of the people who actually have COPD. It is amazingly underdiagnosed. And so the people that fall into these categories are people who have doctors who have classified them as having COPD. There are many people with early COPD who don't realize that they have it.
So we want to talk, and we'll get into that as we talk about, signs and symptoms and how to recognize this. Is there seems to be an incidence in the southern states, say the southeastern states, looks like Mississippi, Arkansas, Alabama, Tennessee, seems to be higher in those states. Is there a correlation there?
Correlation with tobacco use.
Tobacco use is higher in that part of the country.
Yes, sir.
All right, so we're hearing it again and again that this is probably the #1 killer. Now let's take a moment and go through the different causes of COPD. We've talked about cigarette smoke. I've read that within one cigarette, the commercially manufactured ones, we won't mention their names, Marlboro, Winston, Salem, Cool, but we won't mention the names. There are 5,000 chemical compounds. Are those compounds that cigarette makers put into the cigarettes?
Some of them are added to cigarettes, some of them are naturally occurring with the processing of cigarettes, but there are cool things that you would find in roach spray in a cigarette. And obviously you wouldn't hold a can of roach spray to your mouth and squeeze it, but that's in a cigarette. So there are over 200 known carcinogens in cigarettes.
And there's really no way, I mean, they have these filtered.
There are no safe cigarettes.
There are no safe cigarettes,
No.
all right. And we'll talk about this, the new phenomena, the vaping, am I saying it right?
Correct.
Is it vaping, huh?
Yes, sir.
Vaping, okay. Okay, occupational dust and chemicals.
Right.
We see commercials on television, law firms that are looking at mesothelioma and the asbestos and those types of compounds. Many of them were used in the 60s, maybe 50s, 60s, and 70s in building products or in different processes. And we're learning years later that those were highly carcinogenic.
Right.
Do you see this in your practice?
I see this in my practice, but it's not COPD.
It's not
Okay.
COPD.
So asbestos causes a fibrotic lung process.
Different.
And a mesothelioma is a type of cancer
Okay.
that is caused by asbestos exposure. What they're talking about in the slide are things like just very dusty environments of small dust particles, people who inhale halogenated carbons, the benzenes,
Right.
things like that can
Those
cause
organic solvents that vaporize and
you inhale.
So unless you're working in a hood or a very well open space where you wouldn't ingest a lot of that, you probably should be using some type of respirator where you wouldn't take that in.
And fumes from welding are dangerous.
Okay.
The people who grind and dust all day without mask on. It's just the very, very smallest particles can actually get way down in your lungs. I mean, that's why you have a nose. It filters out a great deal of dirt.
Right.
But the tiniest particles can deposit in your lungs and over time do damage.
And that's what happens. They actually are able to travel through the air passages all the way down into the alveoli and lodge there.
Correct.
And then the body doesn't like that.
It does not. And the normal intact lung has many fine cilia, which are hair-like structures, which brush the dirt out of the lungs, and you expectorate them. When you smoke, the natural cell that lines your lungs with these little hair-like cilia are replaced by the tough skin like on the palm of your hand, and it cannot get that out.
All right, fascinating. All right, well, we talked about tobacco smoke and indoor and outdoor air pollution. So if we lived in Los Angeles in the 70s and 80s, you would go to work and you would be driving in smog, which is what, carbon dioxide and dust and pollen. And so, we look at what happened out there with the density of population and cars and their particular environmental circumstances, their weather. And we see that they've made significant attempts to modify that. Do we have those type of problems here in the Deep Gulf South in St. Tammany Parish?
Not truly. like you said, Los Angeles used to be a hotbed of it. The biggest place we see this currently is like Mexico City, which continues to have horrible smog problems, and third world countries where people actually cook indoors with wood fires and lack of ventilation.
So if you have someone with a diagnosis of COPD and they have, let's say, a wooden fireplace, that
It
could
needs to be well ventilated.
well ventilated for sure.
Yes.
So it may or may not cause a problem, but you need to make sure, as in any time that you're creating any type of toxic fumes or vapors or dust or anything, that you're protected from that.
Correct.
Now, on the other side of the ledger, we're looking at things like infections.
Yes, sir.
So you in your work in the hospital, you get to see people that have really immunocompromised, meaning that they may have some what we call comorbidities, which are other disease factors or diseases that are going on. And because of that, maybe you see more infections in that population, or?
You see more infections in people who have COPD, yes. What this is talking about is people who have severe pneumonias as children can damage the lungs permanently. People who have HIV are more susceptible to developing COPD. Any severe pneumonic process in your lifetime that leaves scarring and damages the lungs can predispose you to the development of COPD later in life.
What about childhood asthma? Does that have an effect?
It does, especially if it's not well treated. And that's one of the things we try to stress to our asthmatics is keep your asthma controlled so that it does not become COPD later in life.
Okay. And I know that, speaking from personal experience, having asthma as a child and then outgrowing it for maybe 20 years or more, and then
surprise, it's back.
Surprise, either as a result of an infection or a virus or a bacteria getting some type of infection, all of a sudden asthma's back again.
Yeah.
Do you see that as a common phenomenon?
I actually have one little 83-year-old who is still upset with me because she was just initially diagnosed with asthma at 83. And she just takes it as a personal insult that I've diagnosed her this way.
Yeah. So really asthma you can have it as a child, it can go away for the rest of your life, or it can reoccur at different times. And when it does reoccur, if not treated successfully, aggressively, and completely, if there is such a thing as completely treating asthma, it's chronic, then you have more of a likelihood of potentially downstream COPD.
Yes, sir.
Yeah. Now, there's an issue here, prematurity. Now, that is fascinating. I understand that when babies are born premature, that but lung development's not where it should be, right?
Correct.
So what happens there?
There seems to be a fairly clear recognition that if the lungs are premature and small when the baby is born, and they do not develop quite as well as they would for a full-term baby, so that the lung never reaches its full capability as a young adult. Lungs age as we get older, and you eventually run out of lung function. If you never hit your peak, then when you slide down the hill as you age, you're starting from a lower starting point.
From a lower starting point.
Yeah.
And you don't have that far to go.
Right.
So is that the prevalence of that? Do you see?
It's increasing as we're saving more and more and more little bitty
babies.
babies.
Tiny babies, yeah.
Yes.
Yeah. And there's really nothing, I mean, you treat symptomatically when the baby is born, right? You provide oxygen and
Surfactant if necessary, correct.
Different. And what does a surfactant do in a female?
Surfactant opens up the airways so that they don't collapse.
Okay.
It's like grease kind of in the lungs that lubricates them and allows them to open up.
Okay. But even with all of that, there's still, that population has a potential later in life to perhaps develop some additional type of diseases.
Correct.
Okay. And we talk about untreated asthma. Untreated asthma, now, when I was practicing retail pharmacy back in the day, there was some over-the-counter asthma medication.
Too dangerous.
Yeah, they're pretty dangerous stuff. But you know, there are a certain number of people that don't want to acknowledge the fact that, you know, hey, this is really something that's serious. And so if asthma is untreated, what happens?
So asthma is reversible airway obstruction by definition. So the airways themselves tighten up. So air goes into the lungs, but then it has trouble getting out. So if you continue to expand that balloon, you rupture the internal structures in that balloon. So instead of having your little bunch of grapes, you now have the big sac in COPD. So it's very important that airway obstruction be minimized so that air flows in and flows out.
Yes, and in our next show, which is part 2 of our presentation, and I sure hope that you stream it. You know, you can download it and stream it, and we'll be giving you the links to be able to watch both of these shows later in our program. You'll be able to learn more about the medication side of what we're just talking about, and our old friend genetics. You know.
Yes.
What we can't do about what we were born with is what we got, right?
There is. And there is also a disease called alpha-1 antitrypsin deficiency, which is a protein misfolding. So the protein doesn't get out of the liver because it's folded wrong genetically. So it doesn't get out of the liver, so it can't go to the lung and protect the lung. The good news is that we do have treatment for that now.
Is that a relatively new treatment for that particular?
It's been out for at least 30 years.
Okay, well that's not a new one then.
But it is infrequent, thankfully.
Thank you, praise the Lord.
Yes.
So the effects of COPD on your body, I'd like to take these one at a time, and we have some very nice clip art here, I see. And I want to thank our Xavier students who assisted in developing this presentation, and also our clinical pharmacy residency program, which Slidell Memorial Hospital is the only hospital in St. Tammany Parish that actually has a fully accredited pharmacy resident program for doctors of pharmacy, and they work very closely with our medical staff, and so we appreciate the research that they've done on all of our presentations. So I'm looking at this picture of this little man. It looks like he's not sleeping well at night.
If you can't breathe, you can't sleep.
Right. So over a period of time, what happens in that situation?
Well, the more fatigued you are, if you don't sleep, you're fatigued. If you're fatigued, you don't exercise. If you don't exercise, you become deconditioned, and it's a vicious spiral.
And so you see that just continuing down and down and down. Mm-hmm. Ultimately, this condition, lack of sleep, it's not really insomnia, is it? It's really, it's because you just you can't breathe.
Correct.
And so you get tired and you're in the spiral. You very could end up in the emergency room with presenting with, oh my God, I have a crisis now, right?
Correct.
Yeah.
Correct.
So I see a picture here of a gentleman who is sort of stooped over and maybe not exercising or not moving too much.
Correct.
And we talked about that.
Right. If you are not breathing well, you can't exercise well because you get short of breath. And the problem is, if you get short of breath walking a mile, you say, well, let me cut that back. I'll just walk half a mile. And then, I'm kind of short of breath at half a mile, so let me just walk out to the mailbox. That makes me short of breath too. And they keep pulling themselves back in so that pretty soon they're stuck inside their homes. Part of that is because of the process of COPD in and itself, and part of it is just you feel short of breath. And we have ways to combat that with pulmonary rehabilitation, which we also offer at Slidell.
Absolutely, and we're going to talk more about that. Difficulty in dressing and difficulty activities of daily living?
Absolutely. The more it progresses, the worse it is. I have patients who can't brush their teeth without being exhausted. And there's the poor group that believes, that wear their oxygen, but then mistakenly think they have to take it off to get in the shower. So by the time they get out of the shower, they're wiped. So we try to tell our patients, leave your oxygen on all the time. It's plastic, dry it off. Dry you off, dry it off.
Right.
Leave it on.
Right. I see a symbol here that says no heavy lifting, no heavy work. Any type of heavy work will cause exhaustion and.
Many times we see patients who present and they say, you know, I just can't carry my groceries in anymore. I'm so short of breath carrying my groceries in. And you realize they're talking 5–10 pounds. So it can be quite debilitating.
And in those situations or with those particular patients that started at a mile, then they rolled it back to a half, and then they rolled it to the mailbox, and then they rolled it to the kitchen.
Yeah.
You indicated that there may be some treatments, and we'll talk hopefully more about what those are to be able to combat some of that and maybe to help them, because even with COPD, is it safe to say that you can exercise if properly treated and
Absolutely.
properly controlled?
And you should.
And you should, because it will help you.
Yes.
Okay, so let's go through now. We've got the symptoms here, and we're looking at some lungs and the chest there. So tiredness and weight loss. Now, you know, if we could, there's this thing of weight loss. If we may be promoting COPD if we could make it a weight loss program. No,
This is bad weight loss.
This is bad weight loss.
Right.
We're talking about losing muscle. We're talking about really becoming emaciated.
Correct.
Is that?
Because when you have severe COPD, you actually spend 50% of your calories breathing. Okay?
As opposed to what, Dr. Park?
3 to 4.
Wow.
So, I mean, it is a huge drain of calories because they have to use more muscles to breathe. They have to breathe faster, and so it is severe. And
so that's where most of your calories are being burned and just trying to breathe and stay alive.
yes, sir,
Frightening.
it is.
Okay, so in the lungs themselves, coughing. You know, if occasionally we get sick, not all the time, but occasionally we get sick. You find that, you know, if you cough and you can't control that cough, it actually, you know, you feel like your muscles are like somebody punched you in the chest, right?
Yeah.
And so coughing is a very common symptom with COPD,
It is.
And you said people will wake up and cough and cough and cough, and then, you know, try to go on with their day, but and it's dry or productive.
Correct. Dry coughing is the most common, but the chronic productive cough we see with people who are still smoking. You know, the smoker's cough
Right.
that you hear about is chronic bronchitis.
Okay. And so now wheezing and chest tightening, and I know that when you get your annual physicals or your semi-annual physicals, if your physicians are putting the stethoscope on your lungs, listening to your lungs, or if you happen to go in and say, you know, I think I'm having trouble breathing, whatever, you listen to the lungs. And what I find fascinating is that with your stethoscope, you can hear things that the human ear, like we can't hear, but you are listening to something very deep, right?
We're listening for wheezes and crackles and rhonchi.
And what does that tell you when you hear those things?
Wheezes are a sound of airway obstruction. So if the airway is tightened, we hear wheezes. We hear crackles when the little alveoli are popping open. So that's an inspiratory noise. And it sounds like Velcro being pulled apart. And then rhonchi is mucus rattling up and down the chest.
Okay.
And obviously when it's pronounced, you can just hear wheezes and rhonchi with your naked ear.
Yeah. I see chest tightness as one of the symptoms.
It is.
That's that can be rather confusing because, you know, if someone comes in, you know, either to your office or to the emergency room and says, I'm having chest pain or chest tightness,
Right.
that's going to trigger a whole set of reactions. That's going to cascade. But you have to look at this in the context of we're dealing with the lungs, not the heart. We're not, even though it of course affects circulation, you're dealing with the lungs. And so tell me about when you have a flare-up. It says a flare-up of chest tightness. Is that common in COPD?
We see COPD exacerbations that produce increased mucus, increased cough, increased chest tightness.
Okay.
Combinations of all three.
So it just kind of it cascades down.
It does, and they become more short of breath to the point where they seek help.
Right. Now ankle swelling, there are a variety of different conditions, diseases that could cause ankles to swell. This is, I didn't really know that COPD would actually cause that, but I see heart failure. We recognize that, you're not moving fluid out of the body as productively as you normally would. So is this one of your common symptoms to see swelling?
This is a late symptom. So this says that the patient has cor pulmonale, that the right side of the heart. We typically, cardiologists like the left side of the heart, pulmonologists are the right side of the heart. So we're dealing with the blood going through the lungs, but to get that blood to go through the lungs, those arteries have to be expanded. If the blood can't go through the lungs, it backs up in the body, and then you have ankle swelling.
All right. So let's talk briefly about the treatment for COPD, and we're going to get into this much more in our next segment. But you have controllers, rescues, and then common sense on the other side, right?
Yes.
So we're going to save a lot of the in-depth talk about this for our next segment, but can you take us briefly through the controllers and the rescues and the difference between the high-level difference between those two?
So the controller medicines are the medicines you want to take every single day, routinely, like you take your blood pressure medicine and your diabetes medicine. No ifs, ands, or buts, you take them, because this is what's going to keep you from having exacerbations. This is what's going to minimize your symptomatology. The rescue medications are for when you're having that flare and you're not breathing as well. These are medicines you can go to every 4 to 6 hours to temporarily improve your breathing.
Okay. And of course, stop smoking, diet, exercise, pulmonary rehabilitation, we'll get into that in our next segment. Oxygen, we're going to talk more about that, and immunizations. I promised you at the beginning of the show that we would have an exciting presentation with Dr. Parker, who is extremely knowledgeable in all of pulmonary medicine in addition to the other board certifications. So to close out, Dr. Parker, what is the outlook for COPD?
The sooner you start treating it, the longer you live, okay? The medicine we have is better and better every year. We're having new medicines that minimize the symptomatology. We can't reverse it, okay? Once you destroy that alveoli, it's gone. The lungs don't make new lungs. It's not like a liver. What you have is what you have. But we can minimize it, and if you take care of yourself and you do all the things on the previous page, you should be able to do much better with your COPD than you would otherwise.
Thank you. So from all of us at HealthQuest, we want to thank Dr. Parker for sharing her knowledge on COPD this morning. And you can see on the screen how to contact Dr. Parker. She is at 1051 Gauze Boulevard. Her telephone number is 985-641-5523. Dr. Parker, from all of us at HealthQuest and in the community, thank you very much.
You're welcome.
Thank you all, and have a healthy day.